Well, happy Tuesday. Thanks for joining us today. I hope that everyone is excited to attend our last webinar and CE event for 2020. We will have more in 21, but this is the last one for this year. You should all know me by now, but there are some newbies on the call. So I'm Dr. Lindsay Wright. I'm the Executive Director for AFOS. And again, we're happy to have you back on this Tuesday talk. Thanks to Luno for their ongoing support and to make this event happen. We will kick off the evening with Dr. Rasa, who will speak to you a bit on how to implement a scalable vision care experience in your practice setting. And then Dr. Lindsay Ferris will present to you 2020 concussion research to clinical care. So that'll be a great talk. We do have some raffle prizes that I'll be giving away. So any of you that were on our virtual meeting, we have brought back the wheel of AFOS, the wheel of fun. And so we will do some raffles. So hang in there with us tonight. Just to review a few things, tomorrow you will receive an email from me with a survey. Please complete the survey. Once you complete the survey, then you will be receiving an email from ARBO with your attendance verification and your certificate. If you had joined us for any of our November events, you should have already received that email and gotten course credits for the classes that you attended. If you didn't, please send me an email and I will look into that and see what happened. Again, you can go check out our website at www.afos2020.org. Check out all the events, especially with 21 coming up. We have more things to announce. As for tonight, out of respect of our presenters, you all have been muted, but we do want your participation. So feel free to chat in the chat box. If you have any questions, though, there is the Q&A box. So please reach out. We will be happy to answer questions. And at the end of both lectures, the presenters would be happy to answer questions. I can unmute you if you prefer. Just raise your hand and you can ask it directly if you would like. Now I would like to introduce Dr. Rasa. She is a lifetime entrepreneur and has been in private practice in the Chicago area for 16 years. And we are happy to have her here and tell you about some new and interesting equipment.
Hi, thank you so much for taking your time to be part of this presentation with me. I'm very excited to present the product that I'll be talking about, which is the iRefract by Luno Technologies. And thank you so much for your service. I am going to go ahead and do a little introduction as far as what we will be talking about. Can everybody hear me?
You are good, yep.
I'm good. I'm having a little trouble controlling my screen for some reason right now. It was working just fine earlier.
Oh, that always happens. Yep.
So
if you hit your arrows, will that move it forward?
It doesn't want to, and I tried it right before, and it was just fine. For whatever reason, it's not allowing me to go forward.
You can, if you want to stop the share and then maybe restart it, and we'll see if that works.
Good. Yeah, I'm going to go ahead and share the screen one more time. Oh my. I think after Dr. Ferris tried hers and then I got on. For some reason, it's not working. Gosh. Let me make sure.
Yeah, I can bring your lecture up in 1 second on my end, and then
that would be great.
Give me 1 second.
I will start introducing myself so there is no downtime. I'm Dr. Rasa Tomolavicius. Everybody knows me in Chicagoland area as Dr. Rasa. I have entered optometry school because my interest was in owning a private practice, and shortly after graduating, I started my journey in private practice. And through the years of practice, I learn to embrace changes and to adapt new things. And that's allowed me to get to the point where I am today. I believe a strong openness to do things differently allowed me to grow my company to the size that it is today. I own 2 optical companies, and in particularly Big City Optical. I started nearly 4 years ago, and we are 11 locations strong today. What allowed me to get to this level of growth? There were a few things. One of them is, like I said, the creativity and the openness to do things a little bit different. Also, I succeeded in building a great team. And then also duplicating that great patient experience. I found a certain mold of practice that worked for me, and I was able to duplicate it with the priority of always keeping that patient care as my utmost goal. When choosing the technology for this type of scalable practice was extremely important, and there comes the iRefract, which I discovered a little bit over a year ago, and I would like to share my stories, how I implemented it, and how it has affected my practice today. At the end, we'll have some questions, so please shoot them down to the inbox, and we'll go ahead and try to answer as many as we can.
It's coming. It's just, for some reason, slow to open. Oh,
I opened it on my end, but it still doesn't allow me to control the screen for whatever reason. I'll go ahead and stop it. If you're able to do it, Lindsay, that'd be great.
Yep, it is just here. Here it comes. Okay, let me share my screen. Are you seeing it?
I do, yes, thank you.
Great, and if you just want to tell me when to move forward, then I will move forward for you.
Yep, let's go ahead and start on the first part of the presentation on how to implement this type of technology. We can go to the next one here. Excellent. So what prompted me to really start to look into this type of technology? Why did I need it? Why did I feel this was a necessity for me to change the flow of the exams that I was doing and to bring it to a different level? This model had to fit my growth. It had to be something that I can implement and grow with the many locations that I open, especially cold starts. And it had to be independent of my expertise. It had to be standardized for patient care to make sure that the customer service is utmost and every time it's the same. It had to communicate with my practices. So the ability of the output of the technology was very important to be integrated into my EMR. The result, of course, of the technology had to be consistent and reliable every time. Unlike, of course, you know, the optometrists, different technicians, they will have different refractions. I needed something that was so consistent and so little remake possibility. So my search was for that type of technology. At the same time, I had no time to teach my staff. I had no downtime building these practices, so it had to be implemented with ease and take very little time, especially with turnover. I needed to make sure that this was something that was easy to pick up for any technician who was scheduled at that office. As Lindsay was saying, I practice in downtown Chicago. The real estate is very expensive, and we can only have a small square footage. So this technology had to be small. It had to take up a very small footprint. And most importantly, I was looking for something that would allow me to spend more time with my patient and to increase the consultation time that I have. So the importance of this technology had to be that it wasn't me that was going to perform, which is better, 1 or 2. I was looking for something that could be outside of my exam room. If we could go to the next one here, let's see, thank you. So how do we collect this data with the iRefract, which of course you see behind me here? It's in one of my practices. We can go to the next slide here, Lindsay. I'll introduce first thing, the mechanism of action. How does this technology work? So to introduce it, I'm going to explain a term called physiological refraction. Physiological refraction is the process on how the light travels through the visual pathways and how is the response and the refraction is captured via the visionics. What this is trying to cover is that it's not just the monocular capture of how the eye kind of goes through the process of accommodation. It goes deeper. It allows the patient's almost physiological responses. The way it works is that it's artificial intelligence driven, and as the light travels through the visual pathways, it detects the relaxation and focusing of the eye, and captures those readings in daylight and nighttime conditions. All of it is happening binocularly, therefore less chances of minusing the patient. And by the time it gives that wavefront reading, it is bracketed with the patient's habitual RX. Therefore leaving very little of the patient's own input when determining that clear, comfortable zone for the patient's comfort zone, to achieve that very nice balance between clear and comfortable vision. We can go to the next one, Lindsay, thank you. So just to show you the screen of what we're working with, the iRefract is controlled via the tablet, and on the tablet we see different things that are displayed here, and most importantly on the right hand side it shows you step-by-step guide on what questions are needed to ask to arrive to that final prescription. All of it is very driven by the artificial intelligence, and also guided by our technicians, where they are trained very easily on how to perform this. The training for the staff, that's the beauty of this thing. It doesn't take long, and the Lenote company provides the support team and the training that is required to understand this equipment fully. In my case, it was Melissa, and she was wonderful. She spent time with our staff, teaching them how to do this test, and it really doesn't take more than about a day or two for everyone to really understand the steps that need to be taken to arrive at that consistent and reliable result for me every time of the refraction. We can go ahead and go to the next screen, thank you. So the result of the iRefract, as I mentioned, it is binocular, therefore eliminating the possibility of over-minusing a patient. Especially for my younger patients, it's a huge plus because it really allows me to understand that refractive status before I even do any retinoscopy or start my subjective with them if I were to double check anything. Although I quickly understood that as a skeptic, I had my manual ways of checking the refraction, and as we all know, the phoropter hasn't changed in 100 years. It still looks the same. We still do, which is better 1 or 2 in semi-dark room. I realized very quickly that this result was almost exactly the same as my 16 years of practice to arrive to that comfortable and clear vision that I would get from my patients. So little by little, I just don't even double check it anymore in most cases. So the results that are provided apart from being binocular, of course, which I love, but also gives you that nighttime and daytime understanding. What is the dioptric power that would best correct the patient? In many cases, I find that the peripheral aberrations and lower order aberrations are definitely cause the dioptric power to be a little bit higher for nighttime vision. Therefore, it opens up the communication with the patient about the aberrations and the difference in possibly correcting their vision for different needs that they might have. It also gives you a little bit of better kind of process into talking about maybe anti-fatigue lenses as well, because you can do quite a bit of binocular testing if you choose with this machine as well. The one thing it also really helps me with is fitting contact lenses. I've done multiple RGP fittings where you have to have super accurate K readings, and I have not had any issues with that as well. We can go to the next screen. Thank you. Here it displays the how the eye refract is performed, how the process takes place. You can see that especially in today's times, working in the pandemic, it's very friendly to social distancing, and the technician is holding the tablet and asking the patient a couple of subjective input questions at the end after the eye refract has already done its wavefront readings and bracketed the patient's RX output here from the digital lensometer, leaving that process of refraction very fast. Actually, it's within 3 minutes that you can arrive at that great result of the refraction. This tablet can be actually remoted in to be controlled remotely as well if the technician is having issues with this. The only thing that you really need in this, other than the technology, is the high-speed internet. And other than that, you have everything here that you can perform this refraction. We can go ahead and go to the next step. Here, this is my staff actually doing the pre-testing. Here, Reese is performing the process of refraction, and Leah is the patient. She is a latent hyperope, and a lot of times when you start the refraction for a patient like Leah, the initial part of the refraction where you go from the objective to subjective is very difficult for the patient, because they're not starting anywhere near like 20/20 vision or 20/30 or 20/40. With the eye refract, their starting point after once the wavefront is already run is actually quite good. And that couple of input pieces from the patient completes it very fast. So a lot of times my patients have reported to me that, oh my God, this process is so much easier than the traditional way of doing things. Even with patients like, for example, I had one patient not too long ago with pellucid degeneration where you had a -8 cylinder, and the eye refract was right on, and luckily he came in wearing his glasses, and we had kind of understanding of what he was used to prior already. But the entire process of refraction took really not much more than a regular -2, -1 combination. So it makes it much easier on patients. It takes the anxiety out of the patient where you're really not sure how to answer, which is better, 1 or 2. And there's a lot of guesswork that happens on the patient. And some already come in saying, oh my God, I don't like this process. But with the eye refract, I haven't had that. And actually opposite, they report the difference, especially those complex prescriptions. So one thing about this setup here as well, too, that I want to touch is that this gives me the consistency of the refraction. The refraction that I produce with the eye refract is less than 1% remake in my practice. So I consider it really strong. My laboratories love me because there are no remakes. The staff is given more responsibility of performing tasks other than data entry, which of course increase the reliability as well when all the information flows electronically. So delegating this process of refraction has really allowed me to be a little bit more in getting to know my patients and growing that practice than actually spending the time, which would be that 10-15 minutes really figuring out the refraction and myself gathering the data. We can go to the next step. So how is this process reimagined in multiple locations? How do I take it and kind of multiply it? My mode of practice is starting up cold starts. I know that everybody comes from a different background, and I know a lot of you doctors are practicing in possibly more like medical settings where there's maybe VA or in general a different type of pace than what I'm used to in a private practice. But I believe this technology can really be incorporated in many different modes of practices. For me, of course, I chose it because I wanted to grow. I wanted to provide that patient care and the customer service to many people across the Chicagoland area, and I've been able to find a way to grow via the technology that I brought into the practice. So I'll talk a little bit about the multiple locations and implementing. If we could go to the next step, Lindsay. So also it's very important to touch on why we need things like that. Why do we need to reimagine the patient flow? And this graph really talks about that we have a lot of patients, and I mean, I know that in many cases in your practices, there might be you might be booked to weeks or maybe even months sometimes in advance. But why do we have this many patients now than maybe ever before? Well, there's statistic that shows that in the pandemic, during these times, the patients are still valuing their eye care, and their eye care needs are very high compared to other fields of healthcare. So we are one of the fields that they think of even right now. But also there's a growing older population, and as we all know, that there's a cumulative damage to eye, and there's more need for glasses, and in general eye care becomes something that's a bit more needed as we age. And with this aging population among us, eye care is really the top needed healthcare department. So if we increase the numbers of patients, how do we continue to provide the great customer service and the great healthcare without sacrificing the quality of care? So there is definitely a need for that. Let's go ahead and go to the next step. Right here, this is one of my cold starts in downtown Chicago. We are about 1,000 square feet. Everything needs to be very compact. As I was saying, my mode of practice is starting cold starts, and out of 11 practices under my company of Big City Optical, 9 of them are cold starts within the last 3.5 years. Is definitely a lot of anxiety starting a brand new practice where you would have no charts, no patients to start out with, and you want to attract them, but they don't always rush in the moment you open the doors. So there's a lot to think about, and if any of you have ever started a private practice, you know what I'm talking about. There's a lot of moving parts, and you have to think very carefully on the budget needs, and of course you want to provide all the best care that you can and invest all in the technology. So for me, it was, of course, the eye refract really was the missing piece that I needed to provide that excellent standardized care. The refraction was one part that I was not able to really standardize prior to the eye refract. Now, I love technology, and I had already brought in the retinal imaging and the OCTs and retinal anterior segment photography and mybography. So my practices are pretty high tech when it comes to examining a patient for their comprehensive needs. The refraction, however, I was still using in some cases the 100-year-old forapter, and in some cases I had auto forapters, but the process of collecting that data was still the same. The optometrist needed to sit there in the dark room and still click the buttons to make sure that we get that clear, comfortable balance for the patient. So for my practices such as this one displayed here, the eye refract was a very, very big plus to be able to open those doctor hours and take care of the patients, even without hiring more optometrists at the start of the cold start. We can go ahead and go to the next step. So this opens up the subject about remote doctoring. How does it work in my practice? The remote doctor process, if you have all the potential data that you can collect on the patient and examine it remotely and tune in to the exam room, just like as I'm doing right now with you via Zoom, and talk to the patient, there is a possibility of giving that best customer care and quality of care while taking a look in depth at the patient's refractive status, which is the eye refract, which is that missing piece that I was looking for. Then I take a look at the retinal imaging. I take a look at the OCTs. I take a look at the anterior segment, digital photography. The technicians collect my data for the visual field, for the pressures, and some of the standardized testing that we do. All of it is uploaded at the click of a button into my EMR, and I can remotely examine it from my other cold start that I'm sitting in, maybe not far away, but I'm able to examine this patient and answer all their questions while taking a look online on my cloud-based system with all the information in front of me. Let's go to the next step. So implementing this new vision care experience, just as a summary here, what I described, and we can press the next button. I think it pops a few more little pointers here. The technician collects the data, they upload everything. I can see it real time, what is the patient's refractive system. I can get on a Zoom call in the exam room and the patient can discuss the all their findings. I can share my screen. I can talk to them about the information that is found right there and then, real time, and answer all their questions. In some cases, of course, the data can show red flags where I would need to see them and I would schedule them for the follow-up. Or because my practices are set up in Chicagoland area, another practice might be less than 5 miles away. If it's something that's needed right there and then, we have 6 full-time doctors on staff that are examining patients. As the practice grows and my probably first 4 practices are at a pace where they're fully booked for the day. So at this point, the eye refract works a little bit different in those practices. They're there to take the efficiency up to the next level. In the mode that I'm describing here, they're here to open up the doctor hours and allow us to grow the practice without the overhead that would be detrimental for a brand new practice. We can go ahead and go to the next step. So a couple of keys to how to implement this patient experience. We'll go ahead and summarize that. So for me, this really gave me the opportunity to be kind of duplicate myself in many offices, where that ability to give me that consistent and reliable reading of the refraction was there as if it was my 16 years of experience producing it. It allowed me to spend more quality time with my patients. Patients are super impressed by the technology. As I was saying, there are no remake rates, and my patients are young. They understand preventative healthcare. In the city, the clientele is about mid-20s to about mid-40s. So in a lot of cases, this is ideal for them. That's what they're looking for. They want to be examined on their time when it's convenient for them. And this allows me to practice this way. The EMR portion, the fact that it's integrated with my EMR that I use is a huge plus because I could never lose this data and everything is so accurate. We are 100% paperless, which is a very nice bonus with the Linode technologies to integrate this for us. It of course allows me to do everything remotely, which has been really the ability to allow me to succeed with a cold start, which for a lot of people, that is definitely a very strong piece of anxiety when starting a practice. We can go to the next one. And I think that completes my presentation, and I would welcome some questions if anybody had some, and Melissa would be also helping us with that too. She's from Linode Technologies, and she was my implementation consultant.
Hi, there is a question here.
Mm-hmm.
It is this system better for medical, high throughout practices, or more refractive based practices, or both?
I would say for both. I had a few conversations with ophthalmologists that have adopted this type of technology, especially refractive type of surgeons, and they absolutely love it. They use this technology to run their 15 lanes of practices daily to allow them to increase that efficiency and base the results towards the patient's needs, let it be pre-surgery, post-surgery monitoring. So in my case, of course, I use it more for routine type of examinations, but there are doctors in ophthalmology field that are implementing it.
Okay. Next question here is, how do you perform a remote slit lamp exam?
So that is possible via digital slit lamp. So we have slit lamps that perform that our technicians are taught how to take images, and they take multiple images. They take mybography images. They can also take videography. And everything is uploaded and it's in my image management portion of my EMR.
Okay. And then I've got another question here. Do you run every patient through the iRefract?
Yes, there has been very, very few cases where I have had a little bit of trouble, and I'm actually happy that the erroneous results were not provided to me by the iRefract. It actually stopped the process. And that was a congenital cataract, and the wavefront just did not go through the cataract that was dense, and it stopped the process. And then it was something that I needed to make sure that I do the refraction my own way that I normally would for that type of patient. So there are a few cases where I would say, you know, and not many. I mean, I would say 95% of my practice is run through the iRefract. Some of the things like binocular vision testing, you could definitely do it on the iRefract. My old ways of doing it, I still do it myself on, you know, manually, but it is possible to do it. The nice thing with the iRefract, in order to create the efficiency, you can set up the protocols. So the protocols in my case are, I want to capture the patient's uncorrected vision. I want to capture the corrected vision with their habitual RX. I want the wavefront reading. I want the refraction. And then I want some sort of like add power. And those are the only things that I set up for my staff to do. If it's something a little bit outside of that, I like to be the one to take care of it. So to answer that question is that most of my refractions are done with the iRefract.
Okay, got another question here. Do you have other ODs working for you in your practices, or do you manage all cases from one location?
No.
Also, hang on. Also, how does it work with young kids 3 to 6 years old?
I do have 6 full-time doctors, and we are opening another location, and I just hired 2 more full-time doctors. So we have a big team of doctors, and because of the growth and the pace that we're growing, again, once the practice gets too busy, it's just very difficult to not have the doctor on site. However, the eye refract serves a different purpose in that case. It serves as almost a second OD to allow the doctor to give a bit more consultation time with the patient. So it really affects the patient exam flow. It gives that extra 10-15 minutes to just for the patient to sit with the doctor and talk, review the data, and summarize everything. So we do have 6 full-time doctors on and onboarding.
And for kids, I can help answer that one.
Yeah.
Yes, we run kids as long as they're tall enough to stand up to the device and they'll hold still and they don't think we're going to puff them. Yes, you can get really accurate refractions because it's binocular and open field. It takes care of the accommodation. So you get really good refractions on little kids. And the youngest I've actually done is 5 years old. So here's another question.
And also to add to that one regarding children, there, as I was describing the different protocols that I have set up to run the eye refract process, we can always stop it. If we see that they're fidgeting and they're having a hard time just staying behind it, we can stop it. We can run the wavefront readings and then kind of take it from there. So you don't have to go through the patient input portion if they're 3 years old.
Okay, next question here. How do you correct a patient who has different vision corrections for daytime and nighttime prescriptions findings?
So this really, I think that I'm sure most of you guys talk about like what is their need. You know, do you use screen time like most of us now? Well, I'm going to prescribe some blue light filters for you. What is your line of work? If somebody is a truck driver and they make these long hauls and a lot of it is maybe nighttime driving, I will gear my prescription a little bit more for that. Sometimes patients want separate prescriptions for different things, and I think just really understanding where the patient is coming from and what their visual needs are, the eye refract just really helps you kind of break that down a little bit and start that conversation.
Okay, next question. Any pushback from the state board?
No, I mean, I think that with COVID, with the pandemic, that is becoming a lot more easier than what it ever used to be. So this year, there's a lot of changes with the state board, and I'm sure that every state is a little bit different. And then, of course, you want to look into being providers for different panels, how they view this as well. But in my case, I have not had any.
Okay, next question. How do you train your technicians to use this device? How long does it take for them to get accurate refractions?
So very limited time. So, I mean, if I had to train somebody how to do refraction, I mean, I don't even think I would attempt it. And I think it's a very, very difficult process because there's so much you need to understand. And then those nuances between the doctor and the patient that I know because I'm not a new grad, and, you know, for somebody who doesn't have the background of understanding the eye health and then the refractive status in general, I think it's very difficult to grasp. So somebody who has no background in understanding those things, the eye refract, I think, is easy to train because it is really giving you that step-by-step algorithm guided type of guidance to the tech what to say. And all they have to do is just respond to what the patient says. So it really, there's very little time for training somebody who comes without any background of understanding refractions.
And let me add to that. So I've trained all of Dr. Rosa's techs, And none of them do. I mean, I think there's maybe two who actually knew how to refract beforehand. They're all using the iRefract. They all use it well. I mean, I usually come out to an office and spend about 3 days, going over, trying to show them things that they'll run into, and everybody is using it really well. There's literally steps that the technician's going to follow, like a series of 9 steps, and then the algorithm and in the device, the iRefract itself takes care of that. So it's not the tech who's actually learning how to refract; they're following the steps. Okay, I think this is about our last question here. How does your staff feel about using the iRefract? Was there any trepidation?
No, they really enjoyed having this task delegated to them. It is a new technology. It's exciting for everyone. It's exciting for the patient. The feedback has been really positive, and we have done quite well with the response from our staff. Everybody really enjoys the process, and the fact that these are different things that they may have had done if they are coming with any experience. So for them to take over the refraction process is quite new and exciting, I think.
Okay, and here's one more. Do you still believe refraction is an art?
I think it is. I mean, I know how hard it is to master it. I think that, that I always describe that very clear and comfortable balance needs to be there for the patient to be happy. I think that, this is something it's taken me a while to really understand patient responses, and they're different from different patients, but understanding where they're coming from and who has what needs really, it took me a while, I think. And when it comes to the iRefract, it really does, it's not an auto refractor by any means. So there's definitely more to this. And the way the data is bracketed with the patient's habitual RX and the wavefront readings, it really minimizes that time to allow the patient to get to that clear and comfortable vision much faster than doing a traditional refraction too. So patients have been really positive feedback on this. There are some patients as well that I'd like to mention too that have special needs, and for example, somebody with in a wheelchair. I don't have eye exam lanes that you can move the chair out. So for me to do an iRefract, which is easily approachable for a patient in the wheelchair, and the base goes up and down, and the patient can come really close, and I can gather their uncorrected vision, their habitual RX, their vision through that, and then the refraction, and go through the entire step-by-step refraction. I think that's a huge plus. It's not something that in some cases I've not been able to do for some of my quadriplegic patients especially.
Right, and we consider you, the doctor, the one who has the art of refraction. Your techs are just running through, like I said, questions with an algorithm. So basically, with like Dr. Rasa, we wanted to put a mini Rasa in all her offices, and having the iRefract gives her that ability to basically be there because it's accurate and repeatable. And those difficult patients that still need you are still going to need you.
Absolutely, absolutely. I mean, the doctor needs to be there to really make sense of all the data. So as I was saying multiple times during the presentation, is that the iRefract serves one purpose of yielding that refraction portion that was difficult to do without the optometrist or even technicians that may have been trained in doing this. The problem is that what if they move on and you need to train someone else, it's very difficult to face this turnover for the practice or start new practices and train somebody. So this was a missing link for me that allowed me to incorporate that in my practice along with all the other captures of data that we get on the comprehensive exam and make sense of everything. So the refraction was that one piece that was a missing link.
All right. And let's see, I think we're done with questions at this time. So Lindsay, Dr. Ross and I will hand it back to you.
Great,
Well,
thank you.
thank you so much, Dr. Rasa, for being here, and Melissa for answering, helping to answer these questions. It was very interesting, and I think that for all our members, if you need to and you want to explore some more information, please go to our website under the sponsors tab, and you will find Luno there, and there's a little video that is linked there, and there's more information. You can link to their website and everything through our page. So we're happy to have you. Thank you so much for being here.